reverse mentorship. So when the organizers deemed it fit that I should give a talk on reverse mentorship, I was scratching my head about how to talk and what to talk. This is not a technique. This is more a philosophical thought process. And I thought, after going through some literature, how should an elderly man like me, an old man, or an old surgeon like me, talk about new things in technology? So, how do we see reverse mentorship? So, a definition says it's like a junior trying to teach a senior. Please understand the barriers there. A junior teaches a senior. So, it's a very difficult thing in medical professionals, because when you become senior, you have a lot of ego. To get over the ego and the barrier is a huge problem. So, in the context of surgery, enhancing traditional mentorship approaches by leveraging newer technologies and newer perspectives. So, the aim here is you collaborate between experienced surgeons and younger professionals. And I think in Stavia and many places, we have this challenge of young surgeons coming in and talking about things, and the newer surgeons are finding it difficult, and my previous speakers have alluded to in many, many ways. So this particular cartoon will tell you about how the more senior persons are resistant to innovation, how the more junior ones are agile and they can learn fast. It is not just the muscle memory, it's also our brain processing, which is slower as we grow old. And the difficult thing is, we refuse to admit it. Our barrier is not the junior's difficulty, it's our difficulty. So, why reverse mentorship? The newer generations are more adept at emerging technologies than us. We have to accept it. Skill transfer between younger surgeons and older surgeons is a very difficult thing. My previous speaker has alluded to it. It's a challenge. And it encourages continuous improvement and adaptation of surgical practices. Therefore, you promote innovation. It helps the department, it helps the society. So we know that today we have a lot of innovations in minimally invasive surgery. As my good friend Raghav told that he is a maximally invasive surgeon, I want him to remind us all that all of us were maximally invasive, and we are maximally invasive at the site, only the approach part is minimal. We have very high-end endoscopic systems. We have now robotic assistants. We have fabulous navigation systems. And we are getting into the realm of artificial intelligence, which sometimes to me appears a little scary, because my mind at my age, I cannot understand what AI is, how the younger generations today talk about AI ML. In my OPD, we have all these software guys coming and say, I ask them, what do you do? He says, AI ML. In the first few times, I didn't understand what AI ML is, artificial intelligence, machine learning. And the human learning of AI ML is more important, and I don't know where this is meeting up, and I feel very threatened. So, in technology adoption, how quick should a senior surgeon adopt? I think the adaptation of new technologies to newer surgeons, by newer surgeons, are fast. The older surgeons are hesitant. We give all the reasons to stop learning. Please remember that. Every time I see here, we go back to studies in 1988, 1998, 2008, 2018. To some of the young guys, 5 years is too old. In my time, one generation was 18 years. Today, one generation is 5 years. So, if the study is done in 2019 or before, it's already a generation gap. So, I think if we learn from the junior surgeon, we'll have faster integration of new techniques and tools. It encourages dialogues. So please understand, reverse mentorship is a thing to adopt. In MISS specifically, we keep telling the young surgeons, please do open surgery first and then learn the MISS. I'm not very sure we should say that now, because the new surgeons have greater technology, greater improvisation, faster brains, better imaging, and fantastic tools. We didn't have all that. We relied on our eyes and our minds. Today, you don't have to have your eyes and your minds. The technology does the stuff for you. Can you imagine somebody saying, there is the disc on the skin, there is the facet joint, and I wonder how we came to that. You go back 25, 30 years, even in open surgery, for my first pedicle screw in 1991, I didn't know where the pedicle was after opening the spine. Please understand, in 34, 35 years, the things have changed. I'm seeing a pedicle on the skin. Just that great leap in technology is something we have to understand. So there is a lot of hesitancy from senior professionals. So I request the young surgeons to bear with the senior professionals. We sometimes are imposing because of our ego, but remember, we are trying to learn from you. So there should be an effective knowledge transfer, and we have to understand and harmonize new techniques with traditional practices. So there are a lot of practical applications. For that, we have to have workshops for senior professionals. Remember, MISSAB is doing, MISS is doing, AS is doing, from senior professionals to younger professionals. I think there should also be a reverse, where there should be workshops, training programs, and collaborative research from young surgeons to older surgeons. So this is what's going to happen. See, the video is not playing. The video is not playing. How do I play this? So this is, okay, this is, I borrowed it from this Stavanger University, mixed reality. Now the surgeon sees with an eye everything like this. Everything is seen. You don't need imaging like we used to do. It's all on the skin. You can see in 3D. You put your eye where and everything you can see. Mixed reality. I think this is going to come in the next few years. All the other things that you are learning, everything will be completely different. You can see the inside of a disc as though you are inside, but virtual. And why is it difficult for me? Because I never learnt it. If I don't learn it, I can't understand it. If I can't understand it, I'm scared about it. And all the previous speaker mentioned about how the surgeons feel that their learning has stopped and some new learning is there, and this is where the difficulty is. So what are the strategies? We need to have programs, we need to have sessions like this, and there should be feedback mechanism. And the feedback mechanism should be in a way that it is applicable for elder surgeons, in a way it is presented. So what are the benefits? The older surgeon also gets up-to-date skills, so is upskilling. You have better outcomes, and our healthcare institutions demand, our patients demand improved efficiency and cutting-edge practices. So these are the benefits of reverse mentorship. Surgical techniques get better. There's a bi-directional knowledge, encourages innovation, and improves team collaboration. I don't look at my junior with suspicion, and the junior surgeon will not look at the old surgeon and say he is a has-been. So the future direction is that you should understand emerging technologies will come, will challenge us. We need to have global challenges which will face, and there's a continuous lifelong learning. And is that literature says so? Yeah. A lot of papers say reverse mentorship is very important. There are books. There is so many different terms for reverse mentoring, cross generation reverse osmosis. I mean, it's just a rose by another name. Even companies are doing it. CEOs are learning from juniors. So it's a two-way street. For the senior surgeons, you should let go of ego and superiority. We should understand that there is a generational gap. We should be open for synergy, and we should say we are part of the innovation team. So flip it and reverse it. That's what I say. Just reverse your thought. You can learn from the beginning. There's a lot of reviews available online. In conclusion, it's a very short talk, but I hope you understand, young surgeons, that older surgeons are not has-beens. We are willing to learn. We are eager to learn. Have the patience to teach us. Thank you so much.